Hi. Hello. Hello. I recognize a couple faces. My name is Kevin Henson. I'm still a practicing medic. I started EMS in 1984 and became a medic in 1987. I'm one of the Gomer medics around. I worked for Santa Fe County Fire. I left there as assistant chief in 2002. I was a fire chief in Oregon for 15 years. Came back to chief in Angel Fire for a couple years. Now I work selling to the fire service, including you guys, for a company called Ellen Curtis. So we sell glow bunker gear, MSA air packs, Hurst, extrication equipment, etc. I'm still a practicing medic. I still work PRN for Hamas, so we may run into each other in Sandoval or Rust. Hopefully not downtown, so I'm going to go on downtown. Just to so I can have an idea, how many here are basics? Cool. Intermediates? Medics? Cool. Of the group in here, how many of you were here when I taught this class 3 or 4 years ago? And you came back? Shit, that's cool. I just noticed on my camera, it turns out I cuss a lot because I come from the fire service. So sorry about that. Typically basics absorb this stuff better than medics. And that's because they haven't kind of been brainwashed like medics have been. So for those that were medics, raise your hands again. Who of you, or who's got the least seniority as a medic? Like in years? You? How many years?
Not even like 2 months.
You are perfect. This is so gonna suck to be you today. No, I'm kidding. So you're our parapup. Who's the oldest medic in the room? How many years?
22, 23.
Years as a medic?
As a medic.
So you're the Gomer. You're the Gomer pup.
Oh, yeah.
So there's going to be 1 or 2 slides where we're going to talk about why both of your brains work a little bit differently. And the answer's kind of cool. This class has been as short as 30 minutes. Everybody gets pissed when I do 30 minutes, and at an hour you get frustrated. At about 2.5 to 3.5 hours based off participation, you kind of get into it. There's nothing that's going to be super hard here today, but it's a lot to absorb. So probably the people that raised their hand that heard it before, you need to hear this 2 or 3 times. Not necessarily for me. Dr. Brody's very good at capnography. He's a big fan of it, as is all the consortium docs. And at the end of the lecture, I'll give a couple names of some other good lecturers and a website that you can go to kind of be current. So before I start with my piece, especially medics, what kinds of patients or scenarios, and I'm going to focus on the non-intubated application for a lot of today, using the nasal cannula. So what kinds of patients do you use capnography for?
Asthma.
Asthma?
Sepsis.
What'd you say?
I just said breathing difficulty.
Breathing difficulty? Any respiratory?
Sepsis.
What'd you say?
Sepsis.
Bam! Are you a medic?
Nope.
He just whispered that.
Just sitting next to one.
There's a good one. We're going to have a slide or 2 about that. What else?
Trauma.
Suspected PE.
Trauma, suspected PE,
Codes.
ICP.
codes, ICP, head injuries. All those are good answers. There's a few more.
DKA.
DKA, we'll talk about DKA at the end, especially nuance at DKA. What about making decisions about fluid resuscitation? What about adding it when you're using narcotics? What about adding it when you're mixing narcotics and benzos, which we're not supposed to do, but we still do? Anytime that you're going to be giving, my general rule is I use it on every PED I give any narcotic to. I put it on every fentanyl patient who I've given a 3rd dose, whether it's 50, 50, 50 or 100, 100, 100. We gave 450 mics to somebody in Hamas a week ago. And you could bet that person was on capnography. Found a way to get him Sandoval to accept him too, which is pretty unbelievable as a trauma patient. That was kind of cool. Any others? Any other obvious ones? We're going to talk about every single one of the scenarios that people brought up today. And if any time I say something or I start or it's a little too fast or you disagree with something based on what you've learned before, call it out and let's talk about it. Cool? If somebody will remind me, let's take a break at 2:30. Whoever the smart 2:30 person is, thank you. Just so that it didn't get too much. Probably the most technical part of this lecture is the first 30 minutes, and it's only 5 slides. And then it's just case-based scenarios that will be very real life, where you'll start to kind of have the aha moment. Okay, I talked so long, you quit talking to me. USB come out? Yep, that was perfect. So, I have received compensation in the past from Covidian, Iridian, Physio-Control, Zoll, and Medtronic for teaching. I used to work for Boundtree. You guys are a big customer. So I have sold capnography projects. I'm not being paid to teach here today. Scott Kelly called and asked if I can do the class, and I like you guys, I like the service, so I'm here for you. The connection to these guys, anybody know who Covidian or Iridian is? So they're the real reasons that we have capnography. So back in the 70s, Israeli-based company called Iridian realized that in an enclosed area, the way to have optimal plant growth was to have perfect CO2. So they created the technology that we now call capnography, or CO2 monitoring for plants. After 9/11, everybody was pissed at everybody who sounded Arab, so they changed the name to Covidian, same exact people. And then eventually, am I screwing that up? I just realized I'm getting red on there. Eventually, these two technologies realized they were so big that they gave the technology to everybody. So whether you're Physio-Control, Zoll, Medtronic, Welsh, all the technology that's used in capnography is all comes from Iridian. The medical director of Iridian, Covidian, and eventually Medtronic, sorry, this is why I can't have new things. How many hours of class did you have to take to learn how to do that? Let's see if it goes right to the next slide. The medical director for this technology was a guy named Baruch Kraus. And I want to share a story with you because what I'm about to tell you kind of changed my life 25 years ago with capnography. When we were introduced to capnography in 1997, I was the EMS chief for Santa Fe County Fire. You'll see my bald head in the picture a little bit without still have hair on it. And a study had come out in GEMS saying paramedics must, absolutely must, use capnography for every tube confirmation, which meant every paramedic absolutely hated that because we don't like to be told to do anything. My first capnography class was 6 slides long. This one's 118. The advanced one is 120. I didn't know much about capnography in the beginning, except I was pissed that my medical director made me do it. As I started to learn a little bit more and a little bit more, I kept seeing this doc's name come up in literature. Baruch Kraus, Baruch Kraus, Baruch Kraus. And I had 3 slides that I added, 2 of them that are still in here. And one of the literature searches had his email address. And I thought, I wonder if I email this guy if he would review my deals. So I was a captain at the time. I sent this email, and about a week later, at 7 o'clock in the morning, this guy answers the phone with this heavy accent. Hello, are you Kevin Henson? Yes, I am. Who are you? This is Baruch Kraus. Hold on, please. And then I can hear him giving drugs, telling him what to do the Selleck maneuver, intubate this person. I'm like, what are you doing? And he goes, I am at Boston Children's. I am supervising 8 anesthesiologists. This is the only time that I can return phone calls. I'm like, holy crap, we're gonna have a conversation while you're walking in and out of the theaters? That's what we did. So we talked for a little bit, talked about 9/11, talked about bias, and he says, where in Mexico is New Mexico? And I said, well, it's not, turns out we're US, not anything like that. Is Santa Fe pretty? And I said, yeah, it's a pretty cool town. I grew up there, was raised there. I come to Santa Fe. And I said, no, I'm a captain. I have like 0 authority to do anything. He's like, no, I come for free. And he did. And Baruch came and taught for Santa Fe County, Santa Fe City 6 times for free. When I moved to Oregon, he taught for free for me in Oregon. And a paramedic that used to work under me who moved to Snohomish County, Washington, he went and taught for him for free. I tell you that story to say that find your passion, whether it's ventilation, whether it's EMS, whether it's wildland, whether it's inspection, find your passion and pursue that out. It was really, really cool. It literally changed my life and it changed my perspective. And it's why I'm so passionate about teaching it today. I've probably taught this version of this class several hundred times. So having said all that, that's capnography. If you're in an operating room in the United States, that's what your capnography device looks for. It's buried inside of about a $100,000 multi-waveform machine that's only in the ORs or in electives. It's simply one channel, it looks like channel 1, 2, 3, 4, and that's where it is. That's what the CRNAs and the anesthesiologists call capnography. That's what we call it. So that's my little head when I was in Santa Fe County. That is still the best vent. Do you guys have vents? Do you have that vent?
Yes, sir.
You probably bought it when I was with Downtree. That is absolutely the best vent, and I'm going to tell you a vent story in a bit. We had LifePak 12s. Before LifePak 12s had capnography, it was a standalone unit called a LifeCap and a LifeCap Plus. Physio Control discontinued that because while they worked perfectly, it was the exact same technology. They couldn't print. So you couldn't prove the tube was good in the field. You can only prove that it sucked when the doctor said it sucked, and you're like, well, you dislodged the tube. Everybody moved to having some form of a device that can print, which is now the standard for everybody, so that we can prove that the tubes are good. So there's a Zoll, a Welch, and a Physio from way, way back when. So you told me who you'd learned, how many had learned the class before. Has Darren, Dr. Birdie, specifically lectured on this before?
I don't think so.
Okay. When you've had interactions with receiving docs, have you had much luck? I'll tell you, the Sandoval consortium docs are dialed in. Rust, 50-50. UNM, if you're in the trauma room or the recess room, 100% dialed in. If you're in one of the other rooms, who knows? Those who are basics or intermediates, and be honest, were you taught this in your class? So I gave this class twice at the New Mexico, it's called the JOE, Joint Organization of EMS Education and Instructors. There's still a bunch of instructors at B, I, and P levels that don't understand this and therefore don't teach it. And that's just unfortunate. They just didn't embrace it, or they're a little bit new. This should be a review session. It won't be for all of you, that's okay. But everything I'm going to tell you, with the exception of one slide, will come from data that's at least 15 or 20 years old. All right, old slide. So in capnography, there's two types. There's mainstream and side stream. Who can tell me the difference between mainstream and side stream? Anybody?
I'm gonna say mainstream is gonna be like your inline. It's coming. There's only one in, one out, and then I think with the nasal cannulas, if I believe I heard correctly, it comes from the oxygen comes in from the right side, and then it senses and it reads the CO2 coming from the left side.
Your answer is right to what you just said, but not to this slide. So
Okay.
let's clean it up a little. So, but what you said is not wrong. So mainstream technology is what's going to be in all the operating rooms. Mainstream technology is this kind of fat honking device, almost this big, and it lives connected to the ET. Get that close. It lives connected to the ET tube and the vent circuit. That little sucker right there costs $4,500. When EMS started, that's what we used, and we broke them about every third call. EMS will never use mainstream technology because of that. So what's happening, the way capnography works is the gas comes in, and using infrared light, it measures CO2. With mainstream, the CO2 measurement is happening truly right there. So if you're in the OR, you'll see that little red light emitting, and that's where the measurement's happening. We're not going to use that. Everything we do is side stream. Now what he said wasn't technically wrong, but it's not the answer to side stream. So with side stream on any of the EMS devices, what he said about the right and left nares is correct. But with side stream, the sample starts here, it's got to go through all of this, and it's actually reading it right here, way down here. That is the only difference between mainstream and side stream. An anesthesiologist will say There's a half a second to a second delay to get from here to there, and there is. Beyond that, everything that I'm going to teach you today, it does not matter if it's mainstream or side stream, but everything we're going to do today is side stream. His comment about the right and left, you can get a cannula if it has oxygen, and I had him cut it off just right before he came in, one of them is sucking, meaning it's a pump, and one of them is providing air. You can also buy this without an O2 at all. That often leads to the question, if you had this at 6 liters or so of O2, can it screw up this? And the answer is absolutely not. The only thing that's being measured in that infrared light is CO2. Make sense? Okay. I asked right before if you guys are using this, the answer I heard back was no. Let me just tell you the controversy. So in the beginning, we had these Ronco CO2 detectors that were wrapped in this aluminum foil. And if you asked experienced EMS providers if they work, every one of us said it sucked. If you asked ER nurses, ORs, or anesthesia techs if they work, they said, oh, they work great. And the answer is that's correct for both of them, but here's why. It comes in a pouch. This is not it, I'm just making this up. It comes in a pouch that has a little bit of air. And it's kind of an aluminum foil thing. These are up at Sandoval right now. Where do you think these live in the hospital environment or the operating room environment? They live in a drawer in the crash cart or they're taped to a wall by the suction unit. In other words, they're pristine. Where do they live in EMS? And as soon as I do that, I perf the air, and because it's litmus paper that reacts, within 48 hours, this is going to be a bogus thing and give me a false reading. So that's why EMS says these suck, and then doctors, Dr. Brody would never do this, but doctors say, oh, it's a good backup. We used to carry them as a backup with Santa Fe County because we never used them. Every single time we tried to use them, they failed, and they just made it more confusing. So I was told you guys took them off the trucks. That's a good call because it's just going to confuse people. There's a device that's out there. You guys were actually looking at this about 5 years ago, and I convinced you not to buy it. It looked like a little pulse ox, but right next to the pulse ox imagery, it had a little bar graph that would go up and down and measure and title CO2. No waveform. That's garbage. That doesn't help. That's like doing a 12 lead EKG, covering it up, and going, heart rate's 88. I think that's an anterior MI. You have to be able to see the waveform and the number to make a decision. You can't make real decisions without being able to see both. So you guys don't have that product here, and I'm glad that you don't. I haven't seen another one in New Mexico, but they're out there. So earlier I asked for what you guys are using them for. There's a standard definition of using them. And we're going to talk about some very specific applications here in just a second. If you're ever ventilating a patient, either with a BVM or your vent, you should absolutely be using capnography, and you base changing your vent on your CO2 settings. You can still start out with the standard 12 or whatever you want to start out with, but you base your changes on capnography. So that first circuit to the left, that's your ET circuit, basics and intermediates. Any supraglottic airway connects to that. So that'll connect to an iGel, to a King airway, whatever you're using. They work just fine. The middle one is the cannula that's here. That third slide is answering exactly what he said earlier. Again, all three of those products are side stream products. There are, and I warned Rio about this a long time ago, there are counterfeit products about this out. The trademark patent wore off 2 years ago, and there's a ton of knockoffs of this right now. This is about $600 a case, and you guys chose to continue to buy the right stuff. So the right stuff will always say Ovidian or Medtronic. The other way that you'll know, and I'll pass this around but don't open this up, this thing at the end that looks like brass on the orange tip is not brass, it's gold. And that gold helps make the seal to stop the CO2 long enough for the sample to be read. So invariably when I go to a service that says, hey, our capnography is not working, they got a counterfeit device. And it's not the machine, it's the disposal. But you guys are using good stuff. But that's one of the ways that you tell. The other ones, the other shitty ones, will have a little water trap right here that you can literally pull it apart when they're trying to trap it. This machine, I quit doing it when I freak people out. But this machine and physio, you can literally put this in coffee and let the whole class watch coffee get sucked into the machine. And any BC or above is just losing their mind because that's 35 grand. But it stops because of that piece of gold. It never actually makes it into the machine. Crappy ones, I wouldn't do that with. Okay, so what is capnography? Capnography is the numerical value for end-tidal CO2, which you're going to talk about in just a second. It's the corresponding waveform for each breath, and then there's a connection to the respiratory rate. Those three things are really what you need to assess your airway status. Before I really got into capnography, probably my first 6 months as a basic, I checked respiratory rates. I don't check respiratory rates anymore. Everybody's 6, 12, 18, 30, 40, right? That's just what we do. You'll be blown away paying attention to this number, how many times your patient is profoundly tachypnic, and you didn't realize it because you're just used to saying that. But we don't think that we usually would document somebody's respiratory rate at 40 or 50, but they're actually in that range a lot more than you realize if you're not paying attention to the machine. Okay, this slide, this is a basic slide. Brain, oxygen is needed in the brain, it's needed in the lungs, but then we quit really talking about what's equally important is what comes out, the CO2 that comes out. Oxygenation is pulse oximetry, that's the process of getting O2 to the tissue. We're gonna talk for the next couple hours about the opposite, gas coming out. When I flew, I had a flight nurse, and I said, I want to do all the intubations. And so back then, this is pre-capnography, how do, especially you were the oldest medic, right? So think back to pre this, when you would intubate somebody, you'd confirm tube placement. You get to the ER, what are the ways that the doc confirms your tube is good or not good?
By auscultation.
Number one.
Let's see.
Well, at the physician level, like he listens, he says, you're good. What happens next to the patient? What does he order?
X-ray.
A stat x-ray, right? And the stat x-ray is not to say that the tube is in the esophagus or the trachea, because the patient would already be dead. It's to say, is it right main stemmed? Is it sitting right at the carina? Or is it even too high? That's the real purpose of that. Now, all physicians are still gonna order an x-ray when you bring somebody in. But nowadays, you bring somebody in and you say, I've got an end-tidal of 32 and good breath sounds. I'm not saying I support this. Half the time the docs don't even listen to your chest, to the patient's chest, because they look at capnography and they know your tube is good. The newer docs will still listen and confirm and make sure they know exactly what's going on. So back to this slide. So when I was a basic, I'd measure O2 sats, then I'd check their sugar, and that was about it. I didn't understand or do anything with this piece here. So my flight nurse partner was Barb, and I would intubate patients, and we'd both confirm breath sounds. This is before capnography. And there's one more thing that the physicians would order after the chest x-ray came back. They'd probably do it while they're waiting for the chest x-ray. Anybody remember? They still do this today.
ABGs?
ABGs. So when I would fly patients, I wanted to see what my ABGs were. So what's a normal pH?
7.35 to 7.45.
7.35 to 7.45. How low can it go before they're dead? 6.9. 6.9, you're checking out. How high can it go? It can go higher, 7.6, 7.7. So I would first look at their pH. Then I would look at the PO tube that I'm ventilating because I'm so smart. What's a normal PO2?
80 to 100.
Right now, all you guys. 60 to 100. So I would ventilate them, and I would bring them in feeling quite steadily with PO2s of 400 and 500. And I just was like, I'm awesome. And Barb would look at me like, you're just a flipping idiot. You have no idea what you were doing. The very next value on ABGs is CO2. I had no idea what I was doing. I was psycho-ventilating the patient, because that's what we used to do. What do you think my CO2s were on my patients? Were they high or were they low?
Low.
Low, they were crap. And in fact, I was making my patients worse by psychoventilating, even though they had PO2s of 400 to 500. So if you take somebody, we're gonna talk about this a whole bunch. If the respiratory rate goes up, either by the patient or you, end-tidal CO2 will go down. If the respiratory rate goes down, end-tidal CO2 will go up. Okay, so start to kind of lock that into your brain. You're gonna see scenarios. Capnography is the vital sign for ventilation, which is what we should really assess. Oximetry is the vital sign for oxygenation. Now, be honest, how many of you have been tricked or not believed a result from a pulse oximeter? A bunch. They suck. Light can do it. Red nail polish, gold nail polish, poor perfusion. There's a bunch of things. I've had dead people that have SATs of 98 and they're blue. There's a whole bunch of reasons to not trust oximetry. I have yet to find one reason to not trust capnography. And I'm going to hammer this a bunch. When you go to attach capnography to a patient, and I'm talking the nasal cannula version, you should guess, before you see the number in the waveform, you should guess what do you think it's going to be. And the reason you want to do that is if you hook it up and it's not what you thought it was, you have a zebra. You have a patient who didn't read the book. There is something weird going on and you need to assess further. Does that make sense? If you just blindly look at it and go 20 or 50 or shark fin or whatever it is that you're doing, you're not really learning. So you want to challenge your brain so that when you see something that's not what you think, keep assessing the patient, keep digging further. See if you miss something that's not obvious to you. And again, you're going to see those in just a second. Probably one of the most important slides. So today, when I show you some slides that don't make sense or that you want to question, if you have a change in a patient in any one of these things or one or more of these things, you will see a change in capnography. So what kinds of things could change a patient's cellular metabolism that EMS could do or the patient could do?
Infection.
What'd you say?
Infection.
Infection, sepsis. What about drugs that you give? You think when you give epinephrine to a cardiac arrest patient or a respiratory patient, you think that changes metabolism? Big, big time. Do you think there's a change in metabolism when somebody's hypothermic or hyperthermic? Big time. So that's the first one. Transportation of O2 and CO2 between cells. Anything that's happening in the chest wall. It could be chest trauma, it could be a PE, it could be a major bleed. Anything that's happening in the chest wall will change it. Anything that's compromising ventilation, flail chest, simple pneumo, multi-system trauma, any of those things will change it. So, if you thought you have the patient you expected their end-tidal CO2 to be X and it's really Y, and they have a waveform that doesn't make sense, take this picture back into your brain. You go, what am I missing? It's got to be one of these things that's causing an unusual view or a zebra call that I got to figure out what it is. Let me back up one. Are you a BC? Oh, both of you guys? So I was in Oregon, and all our battalion chiefs were medics, but you still didn't want them touching patients because they didn't do enough. And so we had a community college that had a fire school, and in September it was very hot and humid in Salem, Oregon, and that's when they did their Hell Week. And we would routinely transport 2 or 3 patients a day. These are physically fit, 19-year-olds, and we were just hazing the crap out of them, just everything that you're not supposed to do. So we would take these patients out. So the community college where this happened was called Shemeketa. Try saying that real fast on the radio. So on this particular day, let me back up. Our service did RSI. We did rapid sequence intubation. And we used succinylcholine. And succinylcholine should cause the patient to stop breathing for 6 to 10 minutes, and then they should slowly start to wake up or you need to resedate them. So we did RSI. I wish the state would adopt it, but they haven't. You have to do a special skill for it. So we did it a lot. We're really comfortable with it. So here's the call. Medic 31, PC 32, responded to the Schmecker training facility, reference unconscious firefighter seizing in water. Timeout 1350. Unconscious firefighter seizing in the water. So here's what you hear on the radio. BC 32 en route. BC 32 on scene. Like 20 seconds. We adopted a protocol there that we have for Santa Fe County that if we were going to do an RSI, we called it out on the radio. And when you called it out on the radio, the nearest anybody came in, whether you're a basic, an intermediate, or a medic. We even had a mechanic who would drive code 3 for us, would come just to help. So here's Patrick, he goes, BC 32 on scene, BC 32 initiating RSI. And everybody's like, what the hell, the BC's gonna start RSI? So Patrick gets there, this 19-year-old kid is actively seizing in full bunker gear, and they've got him in the porta tank, and they're holding his head above water. And he's like, what the hell are you guys doing? They said, well, he was on his 5th burn, his 3rd bottle, hint, and he started seizing upstairs, and we brought him downstairs, and we thought he was having a hyperthermic event, so we threw him in the drop tank. He's like, who taught you to do that? And just, firefighters do weird shit when stuff gets weird. So he's like, well, take him off. So they take him out, try getting wet bunker gear off of an unconscious firefighter. So Patrick decides to put a 14 in the guy's neck, which is soaking wet, has somebody hold down the catheter. He's not taped because everything's wet. He pushes the drugs, remember, because he said RSI in progress. He intubates the patient successfully, has capnography on, because it was on all our Life Pack 15s. So one person, a battalion chief, has done all this in about 90 seconds. We had our stat pack bag, which I think you guys have. We have had them set very, very specific for RSI. So the rescue that's coming, the ambulance, has got about a 4-minute response time. BC 32, or I'm sorry, Medic 31 approaching. BC 32, what do you need? Medic 31, I need your Versed. Bring me your Versed, not the stretcher. They're like, what the hell? So if you've done RSI, he shouldn't need Versed yet. He shouldn't need Versed for another 5, 10, 15 minutes. They get there and the patient's starting to wake up. He's intubated, freaking out. They slam him back down with benzos. His end tidal CO2 was 55. Why was it 55? Because he was hyperthermic. Why did he burn through the drug so quickly? Because he was hyperthermic, his metabolic rate was just crazy, crazy high. Make sense? If you didn't think through that zebra call, you could think, I inappropriately dosed him with sucks. I didn't give him enough drug. But they did. And in fact, that call that day changed Hell Week forever for the program. Because he ended up having, he was in the ICU for a long time, his kidney shut down, he almost died. All from just being put in the hot environment over and over and over again. Okay, here's another slide that says the same thing. Capnography depicts respiration, which is a product of metabolism, the transportation of O2 and CO2, and then ventilation to get it in and out. Now, for those that don't truly know what end tidal CO2 is, you're going to see it on a graph in a minute. I'm going to exhale my own end tidal CO2, and when I get to here, that's my highest number. Now, if I'm breathing like this, both of those are my end tidal CO2. Make sense? It can often be referred to as the blood pressure metabolism. And here's the cool thing. You will see changes in EKG. Let me say it before. You will see changes in your end tidal CO2 minutes before you see changes in your EKG, changes in your heart rate, changes in your blood pressure, and changes in your SAT. It is spooky how accurate it is. It is quick. And you'll question it like, that doesn't make sense. It's not working, and it is working. Okay, these next 5 slides, are the ones you really need to pay attention to, and if you don't get it, stop me and let's get it. So first, when you're looking at the waveform, your interval here at the bottom, that's just time. So the longer this is, the longer the exhalation is. So if I'm breathing fast, it's going to be, if I'm breathing slow, okay, then know that this, all the way to here, is a product of exhalation, not inhalation. All we really care about is up to getting to here. I'll give one exception in a minute. So this is just a product of exhalation. Now I'm gonna, when I do this, that's that point right there. So on the vertical axis, if this starts at 0, goes whatever, 5, 10, 15, 20, 25, the higher that is, the higher your number is. That makes sense? 35 to 45 is normal, but we don't intubate people on normal days. And you're gonna see a slide about that. In the beginning, I told everybody 35 to 45 is where you wanna be. And they're like, well, every sick person is not there. Yeah, it's because they're having a shitty day, and so they're on one end of the spectrum or another. Okay, so we're gonna break this down, each of these, 1, 2, 3, 4, and show you exactly what's happening in your body. Phase 1. So phase 1, we don't really care much about. Phase 1 is right here. Who remembers what anatomical dead space is? Besides that guy, because he's new. Anatomical dead space, they teach it at the BLS level.
Isn't it the oxygen that never?
Yeah, it's the O2 in your oropharynx, your nasopharynx, your trachea, really all the way down to your carina. And all that dead airspace does is move the gas, move the gas. Make sense? What's your dead airspace right now, for everybody in this room? Just a guess.
Like in CCs.
Like how in cc's, yeah.
200.
Good. Normal's 150 to 200. A little person, you might say 100. If you smoke or have COPD, you double or triple that number. Okay? So in general, we don't care much about this. Because it's hanging out in my mouth or my nose, there's no CO2 in there. There's just O2 or ambient, whatever's in there. Since there's not much gas in here, you don't really see much. Don't care. That was pretty easy. Do care about this. So phase 2, or this B to C, phase 2 is a combination of the dead space, and now you're getting the alveolar space out. So as you're exhaling, the more you exhale, the more this number goes up. And as it's going up, the value is going from 5, 10, 20, 25, 30. Make sense? It's generally a curve like this. It's not a perfect square. You may think it is just by quickly looking at it, but you're kind of slowly getting it up, and that's your recruitment of the alveoli. That's very important to understand. Everybody got it? Phase 3 is the most important. So phase 3, or the C to D, is called the alveolar plateau. Do not do a radio report and say he had a cool C to D. Do a radio report and say I've got a great alveolar plateau or I have no plateau. They'll know what that means. It should normally just kind of go up just a little bit, and then that point right there, it's going to march out, and whatever that is, that's the number that it's going to give. Make sense? Super important. The last phase, phase 4, is you're done exhaling. Now you're going to take some gas in, which is oxygen. Because there's not normally CO2, I'm going to do it again. There's not normally CO2 in gas, it just drops down and we don't care a whole lot about it. Got it? Here's a slide saying the exact same thing, but it's saying A to B, B to C, C to D. So C to D in that one would be expiratory plateau. I used to tell everybody, you'll never ever hear a doc say he had an awesome B to C. I was in the trauma room about 6 months ago, and a resident said that. I was like, oh, Jesus, now we got to teach him that other thing. The proper way to call it is a plateau. But if a doc or Darren was testing you guys, and he said, would an alveolar plateau be a B to C or a D to E? It's B to C. It's 1, 2, 3, 4. Did it again. All machines in EMS, including yours, all have a trending feature. Everybody, including Rio, turns their trending feature off. We're EMS. We're like this. We don't care what the trends are. All flight programs turn the trend on. For trending to be valuable, it has to be on at least 20 to 30 minutes. Your typical transport isn't that. And if you're only going to look at it the one time that you transport go through to the VA or whatever, I don't know why you do that, you're just not going to be good at it. So for ER and us, we don't look at the trends. An operating room, yeah, they're going to look at the trends. So of all that, the most important to understand is C to D or plateau. Any questions about that so far? Just kind of everything we're going to hit now is going to cover that. So one of the reasons we were told in the beginning that we had to use capnography was to make sure we didn't put the tube in the wrong hole. And then the more you studied that, you were told you had to do 6 full breaths before you would know. I believe you can tell on the first breath if your tube is in the right hole, with one exception. And this is an important one for you guys to know. If PD, if a nurse, like a school nurse, if bystander CPR has been in progress before your arrival, almost all bystander CPR, they psychoventilate. They open that airway and they just blow like hell into it. And because they blow and blow and blow, because they're trying to do the right thing, just doing mouth to mouth, once they fill the lungs, some of that gas is going to end up going down the esophagus. So because of that, if somebody's had a lot of gas incorrectly put in them, EMS isn't going to make this mistake. It's going to be a well-intentioned, non-medically really trained person. It is possible for the first couple breaths to see this kind of business, but once you start ventilating correctly, it'll immediately go to 0, you'll know. We thought this was the #1 reason why EMS was going to go to capnography in the 90s, is in 1990. 35 years later, we know it's like the least thing that happens. But if you did see that, pull the tube, and you're going to see a case of that real quick. So in this slide, if you're just looking at the waveform, that tube is in the trachea. This tube is in the trachea. This tube is in the trachea. That is a great waveform. That's a crappy waveform. So causes where you could go from a good waveform to a crappy one, the #1 cause right here is a cuff that gets torn, that you've intubated somebody, they had dental appliances or a fracture or something. The other time it can happen, used to be a lot for us, but we're not allowed to intubate peds anymore, so it doesn't happen. I will tell you when it would happen the most is days like today. It's a hot day, your rig's sitting out there probably not running, and your ET tubes are like 90 degrees. You go put that in a SIDS code, and because babies are so small, you would put the ET tube in the back of the airway, it just kinks like this. It's so small, and if it did that, you would see that second or third deal. Your tube is still good, don't pull your tube, check your patient. And for all the scenarios that we're going to talk about today, when technology confuses you, go to your patient and reassess, and then start working your way backwards to try to figure it out. I talked about this earlier. So hypoventilation, so if somebody is hypoventilating, their respiratory rate's going down, their end tidal's going to go up. Causes could be we're not ventilating somebody fast enough or with enough volume, or that spike in their metabolic rate that I was telling you about what happened with Patrick's call, or a hyperthermic patient. What kind of medical call could you go on that right in front of you has a decreased respiratory rate before your intervention and a climbing end tidal? You guys run this call probably every day.
Probably drug overdose.
Yeah, what kind of drug?
Any kind of narcotic.
Yep. So your simple narcotic ODs are going to have a decent waveform, if they're not dead yet. They're going to have a decent waveform and an elevated end tidal CO2. Got it? Now eventually, when your fentanyl OD dies, yeah, it's going to go to 0 because he's dead. He's not breathing. But if you had a fentanyl OD that was in the 50s, 60s club, you know that they've been down for a while. How many of you have worked a call in EMS with a narcotic OD who we give Narcan to, who comes up and he wants to beat the shit out of you? All of us have had that call. If you haven't, it's going to happen. Why does that happen?
They're hypoxic.
Hypoxic.
They're hypoxic. So, what if we change your protocol right now today? You're a narcotic OD. I'm going to hook this up you can easily still get a BVM seal with this thing on. So I'm unconscious, unresponsive, breathing at about 4 times a minute. You can set this at 6 or 4 or even leave the damn thing off, doesn't matter. Hook it up, ventilate the patient. As you're ventilating the patient, you started with an end tidal, let's just say, of 52. And you start ventilating the patient slow, effectively, and you're ventilating. What should, once you start to ventilate, what should the end tidal CO2 do? Go up or down? It should go down. Don't give Narcan. Dr. Brody, sorry. Don't give Narcan yet. Wait till you get their number down. Get their number into the, at least the 40s range. Now give your Narcan. Your patient wakes up, but they don't wake up hypoxic. Because they don't wake up hypoxic, they're not combative, scared, and want to beat the crap out of you. They may still be pissed about the high, but the hypoxic rage, which we actually define that goes away simply by using this to decide how long to ventilate. And it may be 5 minutes. Whereas usually we're just cramming the Narcan and wondering why something happens to them, and that's why. Make sense? So that's hypoventilation. We have 2 that are. I just noticed that error. This should say hyper. So if you hyperventilate, you're going to cause the respiratory rate to go down, or tidal volume could go down. The exact opposite of the. I wonder if this is a double slide. It looks like the same slide, doesn't it?
It's the same.
It's the same.
Oh, I thought I already moved them.
No,
Sorry.
you're the same.
There it is.
There you go.
Thank you. So there's the exact opposite thing happening. So let's make it real again. Firefighters, rehab, down firefighter, a rescue, or your 3rd bottle and somebody's acting stupid, altered mentation. Whoever's running that unit says, hey, you're out going to rehab. You should be using end tidal CO2 on every firefighter in rehab. Not for CO, it doesn't measure CO, but to see if they're hyperthermic. If they're hyperthermic, they need fluids, IV, not going back in for the day. If their end tidal CO2 is baseline, if their vitals, if it's baseline, depending on your protocols, maybe they can go back in. We had a deal, a protocol, that if your end tidal CO2 at the rehab when you came out, if it was at 55, you're done for the incident. If it's at 50, we'll put a liter of fluid in you. If at a liter of fluid everything stabilizes again, and it's like if we're working like a big box fire, an industrial fire, you can go back in for 1 bottle. None of that's technical. It's just stuff we need to train people on. But know when to not send somebody back in. You still got crappy entitles because they're going to go down. Obstruction. So all 3 of those waveforms, the tube is in the trachea. But that first waveform is perfect. That second and third, something funky is going on. So I would look in the patient's mouth. I would try to see what's going on. If you have somebody and you've got a cannula on and they're in acute bronchospasm, you're going to see all sorts of weird stuff happening here. You're going to see it in the slide in a minute that says end tidal CO2 does not produce artifact. You can absolutely get artifact with an EKG by doing this, right? We've all seen that call a million times. The only way you're getting artifact from the patient, and I'll demo in a minute, is patient movement or patient talking. So what do you think you do if that's happening, like an asthma event? Tell the patient to stop talking. Tell them to focus on breathing. I'll demo that here in just a second. This is a cool slide to see if receiving physicians know what they're doing. So this is called the curare cleft. It's been around since the 70s. So I know you guys don't RSI here, but I want to go over it anyway. If you had somebody, medics, who you intubated, and you snowed them with some Versed to intubate, let's just say you did that, maybe a head, and it took 10 or 15 of Versed to intubate, how would you know, Fairpuck, how would you know when to give them more Versed?
Well, if you notice the cleft there, that means that they're starting to buck the tube.
No. You can RSI, right?
Yeah.
You can?
No, we can't.
Then you aren't going to see this.
Yeah.
So, but you're right on the next thing. If they start to buck the tube, that's a reason to give it. What else? What besides bucking the tube? What's another reason to give Versed? More Versed. Like a clinical indication.
Well, if they're seizing, but
Seizing,
anxiety.
no, they're still intubated, they're not that high yet.
Oh, I guess I'm
Gomer,
not.
you want to help them out? It's so obvious it's not in your head. If they start to desaturate, their head turns purple. If the heart rate goes up, if they start to tear, in other words, if they start to suffer. And that's how all of EMS was taught. When the patient starts to suffer, get them stoned again. Turns out, if you paralyze somebody with a paralytic and they stop breathing, about 60 seconds before any of that negative stuff we just talked about happens, this happens. This inverted thing is called the curare cleft. When muscle relaxants like succinylcholine, rocuronium, that kind of stuff wear off, the diaphragm wakes up. That's the diaphragm waking up. That's when you give their drugs. We did a radio report from Hamas, a QA on it, and they did the report to press, and they said, hey, we did this, we did that. We are aside, I'll explain that call in just a second. And we saw the curare cleft, so we went ahead and we resedated. And the doc said, what's a curare cleft? I mean, they don't really understand what they're doing yet either. They didn't start to teach this at the ACEP level till about 15 years ago. So old medical directors, of which the consortium didn't have any, they're all dialed in on this, won't understand what this stuff is.
What is the anatomical reasoning for the?
It's a nerve innervation at the diaphragm that causes something, but it's not benzos. Benzos won't do that. Just narcotics that cause. I do actually know the answer. Let me just think it through a minute. It's the repolarization. So succinylcholine is a depolarization agent. It says they begin to repolarize. That's what it is. That's a good question. Medic? This is the reason 30 years ago they wanted us to do this. And yeah, that works, but that seems like it's never going to happen. And you're going to see just a couple slides. It happened to me. Anybody know who Chelsea White is? It happened to me with Chelsea White in the ambulance with me about 18 months ago. So yeah, if that happens, that obviously sucks. So work your way backwards. How many of you know that this machine has an apnea monitor? That's awesome. When everybody raises their hands, I know that department sucks because all the apnea monitors don't go off for 30 seconds. That tells me when somebody's not been breathing, you've caught it before 30 seconds. But if you don't, it's going to make all sorts of noises and whistles and start blowing around. So when I hear services say our apnea alarm always go off, I'm like, here's your sign, that tells me what's going on with you. So again, 35 to 45. If you have a number, that's great. In general, square is good, hump is bad. Let's talk beyond 35 to 45. Okay. This is the same patient. The waveform at the top and the waveform at the bottom is the same patient. Somebody tell me why those two waveforms are different. And the slide actually even tells you if you read the slide carefully. What's the difference between slide 1 and slide 2? I'm sorry, waveform 1 and 2. Top one and bottom one.
Hump versus square.
Do what?
The hump versus square.
Yeah, and so at the top one, how good is the alveolar plateau?
No.
Yeah, it's crap. Now look at the bottom. How good is that plateau? It's perfect. So the patient who does this, the top one, anybody know what that would be? Let me give you a hint. It's a trauma patient. Who would do that? By the way, the numerical value of the first one and the bottom one is exactly the same. Let's just call it 40.
Could it be a pneumo, maybe?
No, not. If it was a pneumo, it wouldn't get better down below. Why would it be the same? Any ideas?
Maybe a collapsed lung and then they
No.
dart it.
This is simple, isolated rib fractures. So then that top slide, this is so perfect. Your machine is failing right now in front of me, which is what I was hoping to show you guys, the weakness for this machine, and it just did it. turn it off and I'll see if it'll do it again. So if you saw this top one, let's just say it was a low-speed bicycle accident, and you get your hands on your chest, and hopefully you do this regularly with any chest trauma, expose them, get your hands on their chest, take a big, deep, full breath, and they go, ah! But as soon as they did that, they got that patient is breathing very, very shallow because they have rib fractures, and it hurts to breathe. But if they can take a deep breath, it's not a big pneumo, they're just breathing shallow because it hurts. Does that make sense? So I've turned this machine on 3 times since I've been here. The first 2 times, it didn't do it, but it just did it in front of me. This is a problem that's known to Zoll. The first place that discovered it in the US was right here in Albuquerque. It was MedFlight Air Ambulance. And it's worse on the M series than it is this device. I'm gonna get sued again by Zoll, aren't I? Zoll knows about this. So the first thing that I would recommend, and I recommended this when I was here the last time, you guys have the ability to have the CO2 line come up on your machine every single time that you turn on the machine. It's turned off for whatever reason, but you have the ability to turn it on. With this device, when you hit CO2, it's very simple to come on, so I get why Zoll people don't do it. With physio, you gotta do like 5 things to get it on. So, like for Hamas, Santa Fe County, lots of people, we have channel A, channel B is lead 2, lead 3, and channel 3 is always CO2, so that it just always comes on instantaneous. The challenge with the Zoll product, I'm gonna turn it on, I'm gonna hit CO2. On the M series, the CO2 is the bottom line and it's gonna be yellow. Watch carefully, and I'm hooked up. If you can't tell, I'm hooked up. We'll see what it does live here. Oh shit, it's up here. Can you hit the CO2 button, because I can't see it.
Yes.
Upside down. So, no. Yep. Thousands. You guys tell me when you see my waveform. 1002, 1003, 1004, 1005, 1006, 1007, 1008, 1009, 2010. Parapup's already intubated me. 10 seconds is way too long. So what happens is if you're doing this, or let's do what really happens in real life, if you're a crew, he's airway guy, he's intubating while somebody's really setting up the combo pads, doing all that stuff. It's absolutely possible with this device to think your tube is not good because it's recalibrating. So that was two for two. So let's do it again, see if it does it. The first 2 times I practiced it, it didn't do it. So I wasn't gonna really hammer it. The M series, it's way worse. Let's turn it this way so these guys can see. Hit the button again. So this is not because Iridium's failing or Covidian is failing. It's embedded in the software. But again, we're probably at second 6, 7. Tell me when it comes on. 8, 9, 10, 11, 12. He's already intubated me. 13. Now he's pulling his tube. He's getting yelled at by that guy. 14 seconds. That's a long time. So I'm not here to say that this device sucks. Just know that this is a weakness that you guys, basics, intermediates, help your medics not make a bad decision. Or if you put in a supraglottic, don't be questioning in the beginning. Now, I'm going to face it this way, then I'll turn it this way. I'm going to kind of breathe shallow and watch my waveform. So all we're caring about is this bottom. Now I'm going to breathe normally, let it recover. Now watch the waveform. So you've watched the waveform doing short humps, you've watched the waveform doing alveolar plateaus. You look at the waveform now and it looks crappy. It looks like there's a bunch of artifact. How can you trust that number? What do you do if you see this waveform that looks like this? What do you do? How do you reassess? Does the machine suck right now? Because this isn't a good waveform. Ask your patient to stop talking. Make sense? This is like one of the easiest visuals to teach people the importance of not talking to the patient. Like sometimes we'll do one person's talking while the other's hooking stuff up. So if the person hooking stuff up is doing the end title, they're going to be seeing crazy numbers. Just stop talking to the patient, 10 or 15. That felt like less than 30 seconds, but that's the noise you don't want to hear in real life. And that's your apnea alarm going off because you're not connected. Cool. Since I'm on video, I'm not going to identify this guy. He's retired fire service. If you know his name, don't call it out. He has no gag reflex for real life. He's fun at parties. And back then, we would intubate him for ACLS refreshers. He would let us intubate him for a 6-pack of beer, Corona. This hand is Rob Laprice. Whoops. That hand is Rob Laprice, who's the head of the 7/8 for Albuquerque Fire. And this is old school. So he's got a stylet in, whereas now we'd have a bougie. He's got the syringe preset. He's got what used to be the best BVM on the market. It's about $250. Now everybody uses disposables. But back then, because that's a $250 BVM and nobody wants to clean out a BVM with a bunch of vomit in it, everybody in the country, and almost the world, bought this little thing. I'm going to point to it on this thing right here. Do you see this thing right here? Anybody know what that is?
Probably like a one-way valve. Maybe?
Yeah, it's a one-way valve called the disposable relief valve, or DRV. And in old school, and they'll hook up to any BVM. If somebody vomits, it gets stuck there. So in old school, all that we would do after the call is we would just take it apart, throw that in the trash, throw the mask in the trash, put a new one, and we were good to go. So back to Santa Fe County, we were doing a lot of really cool key indicators for cardiac arrest management and quality assurance. We QA'd every cardiac arrest. In our first month, not our first month, in a certain month, we had no saves. And we had some really quick responses. Bystander CPR, AED, everybody's dying. And so at the meeting, we're kind of joking like, man, it sucks to get killed in June because nobody came back. Next month, 0 saves out of like 25 codes. And our medical director, she's since passed away, Dr. Laura Kay, she said, something's wrong. What have we changed in our protocol? And we hadn't changed anything. Very experienced medics. She said, we're gonna do mega codes. So she made every shift come in and do mega codes. And it was just totally normal. And we're using training equipment, probably like you guys do in one of your rooms here. She couldn't see the problem. We study them. She said, let's go out to the ambulance. So we take the mega code Kelly, put him on a stretcher. She goes, run the code in the back of the rig. And everybody's like, this is stupid, why are we doing this? So they're running the code, and Troy Smith goes to connect this DRV valve. And the doc says, what's that? And he says, it's a DRV valve. What does that do? So she explains it, we explain it to him. She goes, pull up all the mega codes of everybody we killed in the last 60 days. And she uses the word killed. Like, this isn't gonna be good. So we lay all the code summaries, which are longer than hell, we lay them all out. And she's walking up and down, and she goes, okay, I know what's happening. No one's leaving this room till 2 of you can figure it out and you can't talk to each other. And there's 4 of us in the room, all medics. And so we're all looking and we're studying, and some are VFibs, some are VTAC, some are asystoles. And we were doing the little button when you gave epi or atropine or whatever you're doing back then. And none of us are catching it. We're like, and capnography's on every patient. And she says, okay, study phase 1. And immediately all of us are like, who gives a shit about phase 1? That's the anatomical dead airspace. She goes, just look at it. So we're walking down the line. And at first glance, they all appear normal. They all appeared normal because they were all the same. So remember that slide where I said it's usually just like this? It's like this. every one of them. But still, we're like, it's the anatomical dead space, who cares? She goes, now, go back and look at phase 4. Remember what phase 4 is? After your entitle, it drops. So we go back and we look, and I'm one of the 4. Like, they're all the same. She's like, yeah, now go look at it again. And it's got this slope. And we're like, wait a minute. All these codes, phase 1 is weird and phase 4 is weird. And by the way, we had even brought physio in to service all the life backs in case we like missed an update between month 1 and 2, and they were all working fine. That QA process resulted in a worldwide recall and the eventual foreclosure or bankruptcy of the DRV valve. They made 50,000 defective valves. And little old Santa Fe County Fire found it through capnography. We didn't really advertise about it, and I didn't talk about it for 10 years till after the statute of limitations had run. But it was amazing that capnography caught that, and it was our medical director that caught it. So that's why I said in the beginning, we usually don't care about phase 1 and phase 4, but QA people, if all of a sudden codes that should be coming back aren't, study that stuff and look and see if you have a crappy product or if you've changed to counterfeit end titles or something that doesn't make sense. Okay, back to the partner. So when you went through P school, how did they tell you that you confirmed 2 placement?
So test book answer.
Yep.
They talk about missed.
No, that's not textbook.
But
what's the
test
goal?
answer? Then the golden rule is capno, and then auscultation of the lung sounds and absent epigastric sounds.
So the gold standard, number 1, is visualizing the tube going through the cords. That's number 1. But you don't see that very often. So then number 2 is capno, auscultation of the chest, auscultation of the belly, misting of the tube and Toomey syringe. You can absolutely be tricked by that. So if you were taught that, you can be tricked. If I die, I'm still hot. I'm gonna have misting in my esophagus for 20 minutes. But you were taught, it's not working, there's no wrong remote. You were taught that, and you got out in school, and you did your first intubation. Have you done your first intubation yet?
Yes, sir.
Okay. And it was harder than you thought it was going to be, because all of this crap was happening. People are making noise, they're not being quiet. So it turns out it's harder to confirm just by tube placement. And basics and eyes, this is the same with a king tube or whatever what's your rescue airway are you guys using? Probably eye gels?
LMA.
An LMA. Oh yeah, Dr. Brody, that makes sense. So this, let me go back. So this is what it really is, but we know that capnography can help. We also know that we don't intubate people on a good day, so there's kind of one of your first things. If 35 to 45 is normal, and you find them low, just low, let's just start there. Your goal in your resuscitation is to move them towards 35 to 45. If you find them high, 45 to 75 or 80, your goal is to bring them back. You can bring them, you can resuscitate them back by the way you ventilate them in terms of rate and volume, the way you resuscitate them in terms of IV fluids, and the way you care for them in terms of drugs. So when I teach an ACLS refresher, everything is based on capnography. And it ends up being better medicine. And you end up not deviating from ACLS, but it really teaches people why are you giving epinephrine, or why are you giving bicarb? Okay, so, especially medics, what's your typical cardiac arrest states here? What's your typical number that you get in capnography on a dead person?
Less than 10.
You said less than 10? How about you?
Usually around less than 10.
You ever had one higher than 10?
I have.
Have you changed stations?
Yes, sir.
So when you had your higher than 10, were you at a station with a long response time?
It was about the same response time.
So a joke that I do, and this is totally a joke, is I do a slide and I say, if you're Albuquerque Fire, your initial end titles on dead people is probably 18 to 22. If you're Albuquerque Ambulance, your initial end title CO2 is probably 12 to 16. If you're Bernalillo County Fire, it's probably 8 to 12. Now that has nothing to do with the care of the providers or the service. How low your number goes in a cardiac arrest state is based on 2 things. downtime, which includes response time, and pre-existing conditions. So in the Albuquerque Ambulance BCFR perspective, it's all about response times. Clovis, teaching there a couple weeks ago, and their Station 1 guys all have entitled dead people of 26 and above, all of them. Their outstations all have 10 or less. Makes sense, it's their response time. Station 1, the average response time is 3 minutes. 6 and 7, it's 12 to 16 minutes. So it's about downtime. So the higher the number, the better the chances you have of resuscitating somebody. The lower the number, the lower your chance, and I'll give you the exact stat in just a minute. With shock states, all shock states, would you expect the number to be low or high?
Low.
He said low. Anybody else? With all shock states, the number will be low. Hypovolemic, sepsis, anaphylactic. How low the number is, there's a connection of that to the criticality. So you can still be sick, very sick, and still have an entitled CO2 of 35 to 45. That's good. Probably a good chance that person's going to make it or hasn't bled out. But if you're starting to resuscitate a shock patient who's already in the teens or low 20s, that's not good. Asthma patients. Asthma is very tricky. In the last 10 minutes of today, we're going to talk about asthma, and I'm going to really help it make sense. But generally speaking, if somebody's having a severe asthma attack, do you think their entitle's low or high?
High.
High. Why?
Airway constriction.
And
They're not getting proper oxygen exchange in the alveoli, so they're not able to breathe it all off, so it's building up.
they're gas trapped, which is what you said. Yep. What about COPD? Same exact thing. And it just depends on the exacerbation or how far it is. So here's a slide that says the same thing in a different way. If you're taking pictures of the video or the thing, this is a good one to take. So most codes are single digit to 20. Most shock states 10 to 30. Now, if I coded right in front of you right now, boom, I'm dead. And you've got this machine right now, and I don't have a pre-existing condition. I'm just dead. What do you expect my entitle would be if you got on me right away and started ventilating?
Probably 35.
Or normal.
35 to 45, normal, right? Remember that, think about that. So how many of you had a patient that you were working, then they coded in your presence, so witness arrest? That number's also going to be normal, or you watched it slowly go down right before they coded or went into VFib or VF or whatever they did. Anytime you're working on a patient and you see a sudden dramatic change in the number or the waveform, always go back to the patient and start trying to figure it out. If you get an unexpected reading, do not question the capnography, question what your brain is telling you is the chief complaint. If you're doing a rule out head ICP and all of a sudden the number's going down and he's not hyperventilating, your thinking is wrong. You need to change your thinking. You've missed something. We're going to do one case scenario and then we're going to stop. This is a real case. This case involves a New Mexico state senator, and it happened at Pewaukee. So if you don't know, Santa Fe County Medic 50 is literally across the street from the Pewaukee Casino. So we had done all of the AED training for the security guards at Pewaukee. They were good guys. This is back when the latest and greatest AED was called LifePack 500. They were kind of orange. Some of you who've been around for a while remember. So I had a policy, I was now the EMS chief, I had a policy that if you're uniformed, you could not eat in a restaurant or a place that served alcohol. I just thought it sent a bad message. So in typical fire service fashion, they wait till it's a Saturday with a BC from another shift, and they say, hey BC, it's just gonna be the medic crew. We're not gonna tell the engine company, but it's all you can eat shrimp. We go park the rig behind the station and eat. Everybody's already looking, because you guys do this shit all the time, I know. So the BC's like, yeah, he'll never know, you're good to go. So they're at the casino, they have their nice meal. They're literally pulling out of the parking lot. Pewaukee Medic 50, Engine 50, respond Pewaukee Gaming Casino, reference code blue. And they're like, oh, we're busted. Somebody's called in a fake call. This is totally gonna bust us with what's about to happen. Medic 50's en route. Medic 50's on scene. So they're totally busted by the engine company. And then the dispatch comes back. Be advised, CPR is in progress. AED has been deployed. This is 1994. Casino had just opened. So here's how I get the call. And this guy went on to be a very, very good medic. Was one of the 7/8s for Albuquerque Fire. He's since retired from there. I'll just say his first name is Kevin. So Kevin calls me on a Saturday night. He's like, hey, I'm kind of pissed off. Hey, what's going on? Had a code at the casino. How'd it go? Didn't go good. What do you want to talk about? New couches for Station 50. I'm like, what? We want those leather couches that didn't get approved. I'm like, are you being serious right now? He goes, yeah, capnography sucks. We need leather couches. I'm like, I'm so pissed. So I'm like, write it up. We'll talk to you on Monday. And I don't get the leather couch connection. So Monday comes around, we bring in the QA committee. So the way that our QA committee works is the two people who, let's say it happened on B shift. Those 2 people or 5 people or however many was on that call, they come in, and then we get a basic or an intermediate and a medic from the 2 other shifts, A and C shift. And then it would me and the medical director to present the case. So we're going to present the case, or the crew's going to present the case. Well, the cool thing about this code is all of it's captured on video because it's at the casino. The one negative is all the cameras are those things, so we can't see the screen of the life pack, but we can see the call. So you see the ambulance getting ready to pull out, and then all of a sudden, they're turning around, and that's your busted point, because I didn't know they had done that yet. I'm like, what were you doing there? What was going on? So they pull in, crew of 2. What do you think they all took in? They took in everything, except the gurney, which is where they should have put all that shit. But they're carrying all this crap in there, suction, ventilator, life pack, stat pack, or whatever they were, Thomas packs, what we used back then. So now we're watching, now it shifts to the casino. Big guy, bigger than me, he's at the blackjack table, falls backwards in his chair, and we get to see the video. First thing that happens is the dealer yells to the pit boss, pulls all the chips in, stays on the chips, dealer calls for security, I'm sorry, pit boss starts CPR, and within 30 seconds, a security guard is on scene, and they've got their first shock in under a minute. And they do shock, 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 which is what we were doing back then, 200, 300, 360. So they're doing CPR in classic fashion, just exactly what happens today in EMS. As soon as we show up, bystanders stop doing CPR, right? So you can see, Kevin's like, no, keep going, we gotta set our shit up. So they're setting it up. Back then in that system, the paramedic did not operate the life pack in a cardiac arrest. We gave that responsibility to the basic or the intermediate, because all these are AEDs for the first 5 minutes anyway. And we wanted the medic to be focusing on airway and then thinking about drugs. Completely different way of thinking, but it was something that we did. I don't know if they still do it now or not. So Kevin goes down to intubate. He's a big guy, goes down to intubate, and you can see this happening pretty quick. And then you see him pass the tube. His partner has already set up end-tidal CO2. So not this circuit, but the ET circuit is already set up. And he's kind of like got it sitting there. He's got the suction out and turned on. And so you see him intubate. You see him connect end-tidal. You see him ventilate. And he kind of gives it a second look. And he pulls the tube. So he said, okay, what happened, Kevin? And he says, I saw a number, I think it was 12. But I ventilated, and I looked back and it was 0. So I assumed I put the tube in the esophagus and I pulled the tube. Medical director says, good job. And we continue the tape. He goes to re-intubate. He re-intubates, you see him look at the life pack. He leaves the tube in, but he puts the blade in to look again. You see him do this again. You can see him yell quiet in a casino, which you think that helped? So he's listening to breath sounds, chest and belly. He does the old trick, and this is still a good trick to do today. If you're at somebody's head, so airway chair, he lays his arm on the chest and his hand's on the belly, and he ventilates. And he wants to see if he can feel belly movement or chest movement. And we actually see him do the technique. And so Dr. K stops the video and she's like, so far you're doing great. You're doing great. And the partner goes, watch what he's fixing to do now. So then he looks up and he pulls out his trauma shears and he cuts this right on the video. Everybody's like, what the hell? Why did you do that? He goes, capnography was confusing the crap out of me. I went back to old school. Capnography sucks. And I just look at him like, we don't teach that. Like, that doesn't make any sense. So now they're back doing CPR, and his partner, very experienced EMT intermediate, his partner, they've done we were making all the security guards do CPR because we don't want to do that shit. So they're doing a rotation, and his partner goes down to the groin. He's just barely at the groin, and then you see the medic slap his hand away. And the doc's like, whoa, stop, separate. And this is what we always do for QA. Anytime you see something weird, separate them so they can't get their story straight. So we bring in the basic. And we're like, how'd this call go? It was okay. You and Kevin get along okay? Oh yeah, he's great to work with. Why did he cut the capnography? He goes, I have no idea. I've never seen that. Why would you ever do that? Well, you wouldn't. And what's with the hand thing and the slapping of the hand? He goes, why do you think I was in the guy's groin? He goes, I was checking to see if there were pulses with compression. Okay. What's with the hand slap? Well, I was working with the Paragon. What does that mean? You can't tell them anything. They think they know everything. They're flipping idiots. Like, really, that's your answer? Yep. Sit in the corner. Don't say a word when Kevin walks in. Kevin, come in. Kevin, tell us the story again. I stepped that thing because it confused the hell out of me and went back to old school. Okay. Stop. Why did you slap Jim's hand away? Jim's just a basic. And everybody in the room kind of, huh? Because I'm a paramedic. What does that have to do with anything? Well, he's checking pulses. I don't need to check pulses. I got a monitor. 100% wrong. Medic's 100% wrong. Now, and if you guys, the four of you who've heard this before and remember, don't call it out. If you've listened to my lecture, my presentation, and the device never failed, what caused the cardiac arrest that was confirmed on autopsy of a New Mexico state senator? What'd you say?
P.
No. So let's wind the tape backwards. What was their response time?
30 seconds.
Quick.
Super slow. Response time to BLS CPR, 30 seconds. First shock, 60 seconds. Before I gave this presentation, I talked about me and I said, if I died right here, what would you expect? You said 35 to 45? Kevin said that first waveform when he intubated, he thought was 10 or 12. Is that normal? Hell no. He should have been 35 to 45, right? Quick response time, great BLS CPR, great AED. So let's pretend 12 was real. Terrible, terrible number. Let's pretend that he doesn't cut the capnography cord. It would continue to read 0. The capnography device is working correctly. What's the cause of death?
Had he choked?
What'd you say?
Had he choked?
Did you say had he choked?
Yeah.
No, he's just playing at the casino. This is a ruptured abdominal aortic aneurysm. He has bled to death in his chest cavity. Every compression was squish, 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 and all that blood is coming out of his body, out of his aorta, and into his stomach and his retroperitoneum. He's a trauma arrest. Is there anything that we could have done to save that guy? No. Dead was going to stay dead, but Kevin's logic of the life pack, he kept thinking this thing's failing. So remember, I started by saying, think about the zebras. This is a great zebra call. It confused him because he was expecting a high number because he knew it was a witness to arrest. They had shocked him, and he gets there, and the guy's already in asystole, and he gets tons of epi, never gets him back. So this is a classic zebra call that capnography was trying to tell you the right thing, and you had a paramedic who forgot BLS skills. So all trauma arrests, if they've got blood volume and they're not rigored, they should produce a pulse. with compression. That could be crappy, but if they've got an intact supply of system they haven't bled out, you should have at least something weak. And they didn't even get to finish it because of that. And because of that, I made them wait a whole another year for their new leather couches, and I waited till we changed stations. And then they got the new chairs. Cool? Let's take a 10-minute break and we'll keep going.